Hello, everybody. My name is Mr. Derry. I am the European Sales Manager for AutoAxle, and it is a great pleasure for me to welcome you for our webinar with Dr. Malagon. The expected duration of the webinar is about 1 hour. Before I introduce Dr. Malagon, I just want to share with you a few details from a technical point of view. You cannot speak during the webinar, but you have the possibility to send questions through the panel control on the right side of your screen. At the end of the webinar, I will ask the question directly to Dr. Malagon, and he will answer. So it's a great pleasure to see the interest generated by Dr. Malagon, because we have a lot of people connected to this webinar, and to focus on his experience with the combined use of accelerant and aligner. There are many professionals today who want to know how to face the great challenge that orthodontics must face, how to treat complex cases in the altitude patients that require aesthetics and, of course, speed. Dr. Malagon knows perfectly how to combine accelerant and aligner to increase predictability and optimize our complex movements. As you all know, Dr. Malagon has a great experience in the use of aligner. He has his own practice in Madrid, in Spain. He is in Europe in Spain, the only specialist which has been a diamond provider for 8 years in a row. He has treated over 2,000 cases with Invisalign. He is Advantage Elite Club member and member of the European Scientific Committee of Invisalign. He is a clinical speaker. He is also now working with OMCO. He is one of the key opinion leaders initiating Spark aligner in Europe. And of course, he is talking for accelerant. He is also the director of a course which is named University Expert in Orthodontics with Transparent Aligner from the University Alfonso X in Spain, and he is co-director of the Clear Ortho International program, in addition to the clinical master in digital orthodontics with alignment technology in Sao Paulo. Now, please, Ivan, go ahead with your presentation, and I will speak later for the question.
Okay, thank you very much for the introduction, Jean-Luc. I want to say thank you to everybody, to all doctors, every doctors that are spending time with me for the next 60 minutes. I will try my best. People who know me will know perfectly that I love to share what I'm doing, and that's why AutoAxle invite me to share what I'm doing. I love orthodontists. I love getting good outcomes. I want to improve every single day, and that's why I love to share all those things with you, partners. For sure, you have experience working with aligners, using different kind of appliances to get beautiful results. And in my opinion, that device made of plastic and rubber, who is called accelerant, is of course, apparently it's simple, but it's giving me an added value when it comes to get a better reaction of the soft and hard tissues, the tissues that are supporting the teeth during the ortho treatment, ortho movements. So that, in my opinion, is very important. It's not even an option most of the times when it comes to offer a better reaction of the tissues when we are trying to move teeth, because for sure at the end of the treatment we want to have good consolidation of bone and of course stability of our cases. I will explain what accelerant means for me, because well, it's at the end it's a small device that is making some vibrations, micropulse forces, and this is nothing but this, but of course it's helping me to get better reaction to the tissues. And for me it's very important not only to move the teeth to the right position, but it's very important for me to expect a better reaction to all the structures that are surrounding the teeth. I have selected a few cases for you to understand my way of trying to find excellence, and not only talking about movement, but talking about finishing. Okay. Let me a second, because I'm working in my clinic. I'm so sorry, but the rest of doctors are working and I'm listening to a lot of sound. So give me 5 seconds because I need to tell them. I'm here again. I have to be hard because it's impossible when you are working with 18 women in my clinic. Can you imagine? Okay. Have selected 7 cases for today. I think I will not have time enough because I love to stay with cases, and for sure you will pay attention to a lot of details. You will see my pictures. I try to give my best quality in my records for you to see every single detail, because this is the key for explaining what I want to explain. The first case of open bite is that guy. You can see, well, the patient is biting from premolars to the back. We have a consolidated open bite. You can see that, of course, for sure, the tongue is getting between upper and lower incisors. This is constricted. You can see that the torque of canines and premolars is very negative. Of course, we should understand when we are sending those kind of STL files, those initial records to technicians. I don't mind if it's Invisalign or if it's Spark aligners from OMCO. Technicians usually will start extruding incisors when they find an open bite, and for sure this is not the way. Most of the open bites, although this is consolidated, even skeletal like this one, if we would have time to show cephalometries or lateral x-rays, you will see that is in terms of traditional cephalometries and values for cephalometries is surgical, because the open bite is skeletal, not only dental. So that many times the technicians try to extrude from the beginning, and this is not the way, because many times those kinds of open bites are created because of negative torque of premolars and molars, so that we find very constricted arches and pre-contact between buccal cusps. So this is the initial situation. You can see, of course, that we have big instability signs. We find retractions of gums. You can see, for example, first premolar lower right, the 44 have a big retraction, even canines, because for sure the guides are overloaded. The negative torque of that premolar and the forces that the upper ones are transmitting to the lower is very bad for the support. So that we should take care of the engagement. We should take care of the sequence to get a better torque of premolars. This is very important. Usually, if we have to expand, we should expect predictability during retraction of incisors. So that sequence of expansion and retraction of incisors give us also predictability in extrusion of incisors. But in that case, for example, I didn't want to do that because I didn't want to extrude incisors in order not to show too much gums. If you have seen at the beginning, during smile, when it's forcing a bit, it's showing a bit of gum, and I don't want to increase too much that thing. So I planned in a sequenced way intrusion of premolars and intrusion of molars, and once I had the good engagement, I had to extrude incisors, but always vertical movements have to be done at the end, not before. If we do at the end of a treatment, we have a good engagement in molars, we have better anchorage in order not to misfit the aligners. This is the clean check I planned. You can see that I'm not extruding incisors till aligner number 19. So till aligner 19, I'm creating protrusion of lateral incisors, upper lateral incisors, and intrusion of premolars and molars. From aligner 19, then I stop in the posterior areas, the movement, and then I start extruding from canine to canine, and then I will expect a better engagement with the virtual jump that you see at the end. This is the second phase. This is what I got after 29 aligners. You can see aligner number 0. So we closed after a few months, after seven months of treatment, we closed the open bite, creating better transversal arches and engaging perfectly premolars and molars, antagonist premolars and molars. Then that second phase was related to create better negative torque of roots, especially in the lower arch. If you pay attention to that second phase or phase refinement, look at 43 and 44. I am doing pure negative root torque to improve the situation of the root into the bone in the lower maxillary. This is very important to improve the reaction of the tissues. And here in that kind of movements is when Accelerant helped me a lot, because of course it's a difficult movement because it's almost a pure movement of the root, and I need the ligaments are stimulated not only by the forces we are applying with aligners, but also with the micro force pulse forces that we are applying with Accelerant. If my patient in that case, for example, is not accepting to be treated using Accelerant, I cannot tell them that I will improve also the support. So I'm not only trying to close the open bite or to improve the alignment, but I want to improve the situation of the bone and the situation of the gums. And I know that I am getting that kind of things doing my biomechanics, doing my protocols of treatment, and using Accelerant. I have no doubt. You see, for example, this is the first picture at the beginning. It's an open bite, maybe around 5 millimeters anterior open bite. And this is after the second phase. You can see from the beginning to the end of the treatment how I have centered perfectly the midlines. I've restored the lateral incisors because you see at the beginning they are very small, and I told the patient at the beginning, of course, that Bolton discrepancy had to be restored at the end. But you can see, for example, how we have closed the open bite. And the most important thing is, if you pay attention to the gums, are globally better at the end of treatment than at the beginning. Of course, this is stable. If you pay attention, for example, to 44, look at that root that is exposed, because of course the forces and the tipping of that premolar is making loose the bone, and that's why the recessions are there. After the first phase, we are doing this. I am intruding the third molar in the lower arch. I'm intruding lower molars as well, and expecting that virtual jump at the end. I need to change the tipping of canine and premolar in the lower area. As you can see, it's around 12 degrees distal crown tipping. You see how I'm not extruding incisors till aligner 19, just in the moment that I'm not moving the upper molars or premolars. This is the second phase in which the open bite was closed, and when I'm giving negative root torque and changing the tipping of canine and premolar in the lower arch. This is very important to improve the soft tissues area. So look at, for example, 43 and 44. This is the beginning, not only the open bite, that for sure is very important for me. This is the lateral view. We start in that situation, and this is after the second phase. You can see, for example, the root in 44 from that situation to this one, how it's reacting much better, and we are into the treatment. It's not finished for sure. We have to do another refinement for a few aligners, only to change the tipping, a bit better tipping for canine and premolar, but compare the reactions of tissues in 43 and 44, and also, of course, we have we have got very good predictability of the open bite, changing the transversal dimension and creating a good sequence in order to intrude molars, as you will see later in the next clean check. You can see I have a limitation in that area. You can see in the lower arch left side, you can see an implant. The one who is in place of the 6 of the 36 is an implant, so I could not move that implant for sure. But I had to improve the extrusion of the 37. That 37 is inclined. Of course, it was filling the space of the 36, and it's inclined so that the patient were losing a lot of support of bone and gums. So I have to improve it and give negative root torque to that molar to get that kind of difficult movements that is upright in that molar, a molar that I don't want to upright distalizing, but I have to extrude from mesial cusp. I need to use that forces that applies with accelerant in order to improve the reaction of the ligaments. It's my recommendation. So this is the clean check. You see that I'm intruding the upper molars and premolars, and I'm extruding the mesial cusp of the 47, and I'm expecting at the end a virtual jump, of course, because I know where every single cusp have to engage into the fossa of the antagonist fossa. This is the second phase, first refinement. You see how I close the open bite, how we have got almost every single detail to finish the case, but I have to improve a bit more, given that negative root torque, especially to lower left molars. So that this is the initial picture. This is the final picture. It's not finished the case, but you can see the engagement of premolars. You can see the canines, premolars in class 1. But the most important and interesting thing is that I'm engaging much better the first molar, the second molar lower arch, and for sure I am closing the open bite in a few months using aligners, and for sure the reaction of tissues is very, very good because also I am using accelerant. This is the upper arch at the beginning. And you see that I'm protruding incisors, I'm expanding, and I can do simultaneous movement of expansion and protrusion of incisors because I am constricting the third molar in the left side. This is very important. That constriction allows me to do that simultaneous movements. If the third molar is not existing, or I don't want to constrict that, or I forget to move that wisdom teeth, I cannot do that movements of expansion and protrusion same time because I will misfit the aligners, especially on lateral incisors that are especially smaller than ideal. So this is not predictable if I want to expand and protrude or proplan incisors if I don't have to constrict second or third molars. It's part of my protocols, my CSA protocols, computerized smile architecture protocols, and of course it's made of 96 values. In those 96 values, I teach my audience, my people, my doctors who are coming, I teach them how to make every single malocclusion be predictable with very good outcomes. You see, this is the initial arch shape, the upper arch shape. This is after a treatment. You can compare how we changed the arch shape. In the lower arch with that implant, you see from the beginning, we move the teeth, we push the incisors, we rotate the canines. The most important thing here is that second phase in which I'm doing that negative torque of 43 and 44. You see? Pay attention to 43 and 44, and also 37 and 38, in which I am constricting them and I'm giving them negative root torque, because the torque at the beginning was very negative, so that the curve of Wilson was very high. And if the curve of Wilson is very high, for sure, the contact between antagonists is very bad for the tissues who are supporting the teeth. So that it's very easy that we lose gum because we are losing bone. This is the initial arch shape in the lower arch, and this is the final one. You see that we are getting good contact points, good alignment, and good bone. We are creating good bone in buccal area also, and putting the roots into the bone. So if we create that symmetry, if we change the torques, we will get a wider smile, better smile. The patient will be able to close the open bite, as you can see, from that situation to this one, with restoration of incisors from this to this. And for sure, you can see how the smile is much better. The patient feels much more comfortable, and for sure, this is stable using Vivera retainers or any kind of removable retainers at night. I have a different or special way of maintenance, but I'm not using ever fixed retainers. This is a video for you to see in movement, dynamic, how the patient feels right now, and you will see that although this is in Spanish, is very grateful. He's telling that he's very happy with his smile. He only now for him is the only thing important now is the whitening. You can see that the open bite is closed perfectly. We have got good symmetry, good change of torques, good reaction of soft tissues. This is why we are understanding perfectly the biomechanics with aligners, and for sure, I recommend you to use Acceledent because it will make better response of all the tissues that have to help you to move teeth with good predictability and for sure with better reaction of tissues. The case number 2 is a case who came to my clinic. It's a difficult case. Came to my clinic after visiting 4 other partners of me, orthodontists, and the rest 4 previously told the patient that with orthodontics we could not improve, told the patient that we should do a orthodontic surgery, and even making the orthodontic surgery, maybe they were not able to get good results. So the patient came to me, and I was making my records, my studies, orthodontic study. I practice posturology. I understand the reaction of a very bad malocclusion to the TMJ and to all the muscles that are surrounding the teeth. I mean the facial muscles and the muscles in the neck, and understanding how the patient was biting and the reaction of the vertebra to that kind of biting. I understood that we could treat this without any surgery, trying to close that open bite only with aligners, and at the end of the treatment, restoring the edges to improve the proportions of the teeth because the edges were a bit erosioned. Another handicap is the patient in the right side, upper right side, is a big bridge. So of course we cannot move it, but we could move the rest, expand and create a better arch shape for us to improve that open bite that is very similar to the previous one in the previous case. So this is what I planned. I had to change and expand to change the torque of premolars upper and lower and improve the situation between them. And once I got a better engagement, then I had to extrude incisors. First is till aligner number 28. I was expanding, changing torques and retruding and extruding relatively. And after aligner 29, I think, or something like this, let me check it, 28, from aligner 28, then I was extruding because at the beginning I was aligning incisors. So you see that I'm protruding lateral incisors and retruding central incisors, and then the whole block from canine to canine, extrusion upper and lower. It works very well with aligners if you understand the sequence. For sure, if patient is not allowing me to use Acceledent, I cannot promise anything to the patient because the reaction of the tissues is not going to be the same. So of course I cannot compare same patients with or without Acceledent, but for sure in that kind of difficult cases in which I need good reaction of the gums and ligaments, I need to use Acceledent, I have no doubt. You can see after the first phase, this is initial, maybe 7 millimeters open bite, how we are in that situation. It's close, but we have to restore the edges from lateral to lateral. Well, to be honest, from canine to canine, we should restore the edges, but we have closed perfectly the open bite. And look at the gums in incisors, how the consistency, the architecture, the coloration, and the reaction of the gums, upper and lower, is awesome. You can see the lower incisors, how we're changing the tipping, and how the reaction of the exostosis is even better at the end than at the beginning. You see in the upper jaw that I have to constrict the second molar, I have to expand the rest, but the bridge in the right side, of course, I cannot do it, but I have to change the the torque of every single teeth in the rest of the arch to improve the engagement. You see how I'm expanding and changing torques of premolars, but this is very important to constrict the second molars because it allows me to procline incisors from the beginning, especially lateral incisors, to improve the alignment. And once I have better engagement in molars and align incisors completely aligned, then I can extrude them with gingival double attachments in palatal areas. But if I don't align them at the beginning, I cannot extrude them from the beginning. This is impossible. First of all, because I don't have a space, and second, because if the roots from canine to canine are not almost parallel, the force of the aligner will not allow you to extrude. That is a less predictable movement. So we should align before extruding, pure extrusion. This is the initial picture of the upper jaw. This is the upper picture of the second phase. This is after the second phase. I remove the attachments and I help with elastics. You see those buttons, metal buttons. The patient was using 6 hours a day, elastics, vertical elastics to the lower arch to improve the situation of the open bite. This is the initial picture of the lower arch. We can see, since the crowns of premolars are very constricted, very negative torque, we can see very easily the reaction of the bone. You can see those mandibular torus, those exostosis. This is not casual. I'm going to publish an article in JCO next year about the reaction of hard tissues to that kind of malocclusion, and it's awesome when I'm discovering, because it's a proportional and direct reaction of those kind of tissues to very bad engagement or not perfect engagement, and this is very interesting. You can see how I'm expanding the premolars, changing torques in a low frequency forces, and I am expanding not in the standard forces and moving 0.18 millimeters each aligner, limiting the standard speed, because in that case I considered that I wanted to do less movement with each aligner but change aligners every 5 days. So it was less than 1 year treatment using Accelerant. You see at the beginning and you see at the end how we align the teeth perfectly, and we have changed the torques of premolars in order to close that open bite and to engage better, to have better support for the rest of life of patient. You can see in the right side the big open bite, and now how it is, even with the same bridge at the end of a treatment. For sure, we have to remove that bridge to do a new one, to remove attachments, maybe do whitening, maybe do restorations. This is during ortho treatment with aligners, and look at the differences, and look at the bone, and look at the gums, how it's reacting. This is awesome. That reaction can be expected with braces ever, because the forces we're applying with braces is around 10 times higher than the one that we are applying with aligners. And for sure, this is not good enough for the biology to get the cytokines and the interleukins and all the cells that have to arrive to apport that blood and plasma supply to improve the reaction of tissues with the ortho stimulation. So I have no doubt that soft forces that we are applying with aligners help with Accelerant is the 21st century orthodontics to improve not only the alignment and the speed of treatment, but also the durability of the stomatognathic system and the maintenance and retention of our results. In the other side, we had to intrude the first molar, of course, in order to place an implant at the end of the treatment, and we had to extrude incisors around 3-4 millimeters each area, upper and lower, because it's around 7 millimeters open bite. The curve of Spe in the lower arch is very inverted, and in the upper jaw is very augmented. So I have to intrude molars and premolars, extrude upper incisors and canines, and also extrude incisors and lower canines. So you see how I'm doing. I'm intruding the molar, the upper first molar in the distal area. When this is engaged, then I have to extrude incisors upper and lower to get that situation. So this is the initial picture. This is the final picture. You can compare incisors. Can you see central incisors from this to this, from this to this? And also, of course, you see the edges. We have to restore the upper edges of lateral and central incisors and also the lower to improve the overbite. This is the initial picture of the patient. This is after the first phase, how this is almost closed or closed, maybe closed. We have to restore the edges only. And you see how we have improved a lot the smile of the patient. And you can see here in the video how the patient is very happy also. And you can see that the bite is completely closed. We just have to, it's telling that previous dentist told her that the only way to improve this was with surgery, but after my treatment, she was very happy with the open bite closed. I'm showing the clean check of the patient for her to see how we started and how we are in treatment. All those cases are not finished. We are in process, but I wanted to show you that it's a very good outcome in a few months using also Accelerant. Sorry. Let me show you a third case of crossbite. This crossbite is another crossbite. That guy is coming from a few hundred kilometers from Madrid. My clinic, my office is in Madrid in the city center, and he's coming from Marbella in the south of Spain because he was visiting a few partners of us, orthodontics as well, and they all told that guy that they could not treat it without surgery, without orthodontic surgery. And well, you can see this is a very consolidated crossbite. This is a bilateral crossbite. It's almost complete in the left side, very consolidated crossbite with an inverted overbite, lateral overbite, that it makes difficulty, of course. To treat this without any surgery, we should take care of the inclination of premolars and canines. If we treat with braces, for example, imagine we bone braces in the upper jaw to jump that crossbite. Since the moment at the beginning we are using rounded wires, not square or rectangular wires. So from the beginning with braces, maybe we can jump that bite with turbo bites or whatever. But for sure, we will jump it, but we will incline the premolars and molars, and for sure that torque will make that the soft tissues are suffering a lot. And for sure, we will lose gums and we will lose bone, because although at the end of a treatment we can change wires, we can make to higher positions with wires, rectangular wires, even using elastics, vertical elastics to get the final torque. During the first time of the treatment with braces, we are applying too much forces and we are inclining to jump that bite with a wire that is rounded, so the inclination is very bad for the tissues that are supporting teeth. With aligners, we can press in palatal area, so we can push very close to the center of resistance, and we can apply forces all along the palatal area, the palatal surface of premolars and molars, so that we can control in a better way the inclination, the torque of those premolars and molars, So if I have to expand, imagine 5 millimeters, because I have to expand 5 millimeters each side, 5 millimeters in the left side and 3.5 in the right side, it's almost 9 millimeters expansion. If I don't use aligners and I don't make the proper sequence, for sure I will maybe align the teeth, but I will destroy the system. So this is not good at all. Also, you can see that the patient is not having a good hygiene. You can see even the forces that the incisors are transmitting, central incisors are causing that retraction of gums. So we need to take care of it, putting into the bone the root of 41. For sure, if we take care of it, we will improve during the treatment, and after treatment, for sure, it will be better. Also, at the end of the treatment, we can think about graft, but we cannot think about cleaning. Now we have to clean, of course, but no graft at the beginning, because if we put a graft now at the beginning with the forces that are transmitting between incisors, we will lose a graft or a big part of the graft. I treated that patient using spark aligners. This is not Invisalign. I'm working a lot also with spark aligners. I'm so surprised about the efficiency and the accuracy of aligners made by Onco. You know, Onco, they have been or they are the leaders in orthodontics with Damon braces and Insignia, and now we are in a big project using spark aligners. Very soon it will be available for you. In Spain, I have the exclusivity, Spain and Portugal, to give the access to spark aligners. It's incredible how it's working. And you can see that I am expanding, maintaining the torque of premolars and canines in the left side to jump that bite. If it's not with aligners, we cannot maintain that torque from the beginning. So this is not good for the tissues. And I don't want only to jump that bite, so that I want to improve the reaction of the bone. And if I control the reaction of the bone during the changing of aligners, for sure I will maintain also the level of the gums during treatment and at the end. So this is the beginning, and I will show you after the first phase of treatment, after 6 months of treatment. Only 6 months is this situation. Look at the beginning, how the bone was, and how it's after the first phase, after 6 months treatment. It's not finished, as I told you, but look at the bone and the gums in the left side where the crossbite was, also in the right side. You see how we are maintaining the leveling of bone and gums. And look at also the reaction of the gums in 41. Compare that situation after 6 months, and it's not finished, as I'm telling you. It's even better during the treatment than at the beginning, because we are placing the roots into the compact bone, into the alveolar bone, sorry, the spongious bone in the lower mandible. You see in the left side that this is very constricted. I am expanding. The molar 36 was lost, almost lost. I started to extrude it, but it was lost because this second molar was suffering a lot during a lot of years. So now in that ending of the first phase, we are planning to extract that molar because it was very bad, so I could not extrude this. But look at the expansion from that situation to that situation after 6 months treatment with aligners. Now it's we have to do a first refinement, second phase, in which I will improve the torque, the buccal root torque of premolars and canines. But look at the reaction of the tissues from that situation to this one. I have expanded 5 millimeters. It's a huge, very beautiful reaction using Accelerant for sure. 20 minutes a day. In the right side, in which the 16, molar 16, is without a crown. The patient lost a crown years ago, so I had to treat this to get a space for the crown, and then at the end of the treatment, we will place a new crown for 16 molar, so that I have to intrude 46 to create a space also for the crown in the upper jaw. I have to jump the crossbite of premolars and even and also the lateral incisor. You see after the first phase, from that situation to this one, look at the premolars. The engagement is very beautiful. From this to this, we are intruding the molar in the upper jaw to put a crown. As you can see, it's without any crown, it's crownless, and I have intruded the lower molar to get it level from second premolar in the lower arch to first molar to improve the space or to get the space for the crown. Look at the lateral incisor, how we have jumped it. We have to restore the edge because it's broken also. But look at the reaction of the tissues in 41 also. Look at the reaction, how it's much better during treatment, taking into account and considering that the patient is not brushing at all the teeth. The hygiene is very bad. This is the upper jaw, very asymmetric, very constricted, asymmetrical constriction. The upper molar is broken. This is the upper jaw sequence with the sapering positions. You see in the sapering position the amount of millimeters I am expanding, both sides, but especially in the left side, is 9 millimeters expansion. It's a lot of expansion, and I am keeping the torque of premolars, and for sure I will even improve more during the second phase or first refinement. I need to use Acceledent to make it better, to get a better quality of tissues. Also, I'm using aligners. The reaction of the ligaments are better using that forces that we're applying with Acceledent. This is after, you see, the difference between that situation to this situation. It's a wider arch, it's a much better arch shape. In the lower arch, I had to constrict the left area to that situation from this to this. And this is the situation of the patient now. You see that the face is more symmetric. I am expanding the left side. I am even improving the reaction of muscles. It's less constricted. It's showing symmetrically both premolars, both sides I mean, because I am expanding and creating a better arch shape upper and lower. In 6 months treatment, that picture is after 6 months treatment, and few partners of us wanted to expand with surgery. Let me show you one last case. I don't have a lot of time, so let me select another one because, well, this is very beautiful also of deep bite, and this one is very beautiful as well. Look at the reaction, for example. Look at the reaction of those tissues. In that patient, you see it's complete deep bite, anterior deep bite. Look at the incisors and look at the exostosis in the buccal area of lower incisors. You see the white areas in which the blood supply is not arriving there, it's not achieving the tissues because of that deep bite. This is after the first phase. Compare the situation in a few months from that situation to this one. I'm exposing lower incisors and giving that negative root torque to lower incisors and canines. But the most beautiful thing is the reaction of the tissues. Compare the situation of the exostosis buccally to the lower incisors in white, and after a few months, look at how they are reacting to that position of incisors. And this is during treatment. This is after a few months, and for sure, this is much better to the supervivency of those teeth and to the stability of the system after the treatment. Wanted to show you. Let me select the last case for you to see how we can, well, for example, this one, this is beautiful also. This patient, we can expect a class 2, of course, because of constriction. The smile is not good at all. It's trying to force that smile, not showing too much teeth and exposing much more in the right side than in the left, because it's much more constricted in the left side than in the right side. It's an asymmetrical overbite as well, and it's constricted bilaterally but asymmetrically. You see the leveling of incisors is not correct, so that the overbite or that deep bite is causing that areas of exostosis buccally to the lower incisors. That areas in white are instability signs that are telling me that something is not working properly, although that guy is very young. This is what I planned. You see that I'm protruding incisors, proclining to center the midline, even in the upper jaw, and using class 2 elastics to improve the situation of the lower mandible and the reaction of the glenoid cavity and the condyle, so that we have to and we can remodel the bone of condyle and glenoid cavity as well. This is awesome what we are doing with elastics using aligners and soft pulse forces as well. So this is the initial situation. This is now how the patient is. It's not only that we are improving the leveling, you will see in the lateral view that now it's class 1, not as the beginning. At the beginning was class 2 in the left side, but look at the reaction of the exostosis in the lower arch, backwards to the lower incisors, how uprighting the incisors and putting the roots into the bone, the reaction of tissues using Acceledent is much better at the end of a treatment than at the beginning. You see the upper jaw that is very constricted from premolar to first molar and expanded, overexpanding second molars. I am constricting second molars. It allows me to protrude incisors at the same time and make simultaneous movement of expansion, changing the torques as well. This is biomechanics with aligners, and we should understand it. If we don't understand it, we will create a lot of open bites because we will overexpand molars, first molar and premolars, so we will create precontacts between premolars, especially first premolars. This is upper jaw. This is the upper jaw after the first phase. So compare that area, incisors, how we are changing the torques and getting good contact points and symmetry between premolars in the lower arch. I was planning that constriction of second molars, protrusion with round tripping of incisors and expansion at the same time. In those cases, round tripping is necessary if I want to put the roots into the bone perfectly, because the forces with aligners have to be transmitted in the same parallelism of roots from canine to canine. This is the lower arch. This is after the treatment, from that situation to that situation. In the left side, you can see that it's a full class 2 because work was very constricted, especially first and second premolar in the left side. So I was planning this thing. I was changing the torques, I was extruding the canine, I was intruding canines and incisors in the lower arch, and I'm expecting that the patient is using the elastics to get remodeling of bone in the glenoid cavity to improve that rotation of the lower mandible to center the midline and to improve the advancement of mandible. So this is the initial situation, and this is the current situation. This is a good class 1. Look at the engagement of premolars. Now, of course, we have to restore the cusp of lower premolars because at the beginning was very constricted. So I have to leave a space in lower premolars to restore the cusps. That's why they are very flat. I have to restore the cusps. I have to leave that space to restore the cusps. But look at the canine class 1 and molar class 1 after treatment with advancement, with elastics, using elastics. In the left side is another class 2, of course. You can see that I'm protruding, expanding, and locking the mandible and using class 2 elastics since the moment I have lateral and frontal overdead, using 4.5 ounces elastics, and after 2 months, 6 ounces. The diameter should be 1/8 to get good force of the elastics. We can remodel the bone and expect the situation of class 1 at the end. In 6 months treatment, we can see that situation. Also, we have to restore the cusp of 44, as you can see from that situation, because was biting cusp against cusp, to that situation in which is very beautiful class 1. And you see we have got a good overdead, overbite, and what is very important for me, good reaction of gums, upper and lower, all over. So if we advance that mandible, if we use the elastics and we unlock the mandible in order to improve the situation of the mandible and the relationship with the upper maxillary, this is the reaction. Look at this. It's like we have done, it appears, it looks like a surgery. Look at the patient, how the projection of the chin, and what is very important, the projection of the angle between the lower lip and the chin. The chin is much better. We can see that the profile is straight, much better profile at the end of the first phase, and it's because we have engaged in class 1, canine and molar class 1, using aligners in a few months and using a proper sequence of elastics, and for sure using Acceledent. That is the key for success when we are talking about reaction of and remodeling of soft tissues. So, Jean-Luc, I think we should stop now. It's 50 minutes now. We have time now for questions. I have seen in the chat that it's very active, so I would like to answer a few of them.
Thanks a lot, Ivan, for your Dr. Malagon, sorry for this presentation. We have no question received from the doctor. I have asked for some question, but maybe they don't find. You have on the right side on the screen, you can send a question. If there's no question, there will be.
Can I read them? Do I have to click here?
Questions? Yes, people can write their questions.
Is there any question or not?
There's no question today. At this moment,
no questions. Wow, this is very strange.
Yeah, I think your explanations were clear enough.
Oh, wow. That's great, doctors. For sure, maybe you have any doubt, or if you have any other doubt, you can contact Jean-Luc or Sandra or the people of OrthoAxel Accelerant, and they will transmit me your doubts, and I'll be so pleased to answer you for sure. We also can be connected in Instagram. I am very active in Instagram, so if you want to write me any message, I will try to be for you whenever you need it.
Ivan, I have some questions which are now sent by some people. There's a doctor asking how many months did the last patient was wearing his elastics?
The whole treatment. I have to start using elastics in class 2, for example, in the moment I have enough overjet, lateral and frontal overjet. At the beginning, as you can see, we have no overjet, so the elastic will not work because the mandible is blocked. So in the moment I have more than 1 millimeter lateral and frontal overjet, then I'm starting using elastics 22 hours a day. This is very important. And I'm starting using elastics 1/8 diameter and 4.5 ounces. After 2 months, when the sphenomandibular ligament is adapted and all the ligaments in the glenoid cavity, in the glenoid capsule, are adapted to the force of around 200 grams, then I change to 6 ounces. After 2 months, 6 ounces to the end of the treatment.
I have a question asking if you can repeat the name of the elastics you are using. I think it's a brand.
I'm using Rocky Mountain.
Okay.
Rocky Mountain is elastics.
There are questions also about the protocol of Accelerant, so maybe I can answer to this one. It's only 20 minutes every day. The preference is to do it in the evening, and yes, you just have to not to bite strongly on the device, but just to put in your mouth and maintain it. We need to have 2 points of contact between the mouthpiece of the Accelerant and the teeth. I have another question. Can you say about your post-treatment stability when you use Accelerant? If you can share your experience, and if you have also some.
The protocol is the same. If I'm using or not Accelerant, the protocol is the same. During the first month, I'm keeping the last aligner with attachments. Then after 1 month, then I check occlusion. If I have to do any occlusal adjustment, I do the occlusal adjustment. And after 1 month, they are using the retainers for 16 hours a day. And I do X-ray to check if I have any increasing of the thickness of any ligament, because maybe I have any pre-contact. If I don't have it, then I will take a scanner for bilateral retainers, and they will wear them for 12 hours, 2 more months. After 5-6 months, they will wear for 8 hours only nights. I check again with another X-ray, and for sure, all the ligaments will have a very good thickness, because the stability, not only in centric movements, but also in lateral movements, in eccentric movements, will be very stable.
I have a question also about your experience on the pain reported by patient when they use Accelelant? Is there any comments or
About payments, you mean?
about the pain? Yeah,
About the what?
the pain,
The
dolor.
pain. The pain. If they
Yeah,
are suffering.
yeah, exactly. Sorry for my
Well,
accent.
yeah, it's demonstrated that they use for 20 minutes a day that vibration, especially at the beginning of every change of aligners, the first 2 days, the pain is much less. We have done a study with 50 patients with and without Accelelant, and from 1 to 10 with Accelelant, they will tell you that the forces or the pain they are suffering when they change aligners in the first 2 days is number 2 with Accelelant and number 6 without Accelelant out of 10, the average.
Okay. And I have also a question regarding the aligner change frequency. I know from my experience here with some doctor in France that some of them are going up to 5 days per aligner. So what is your would say strategy in terms of frequency of aligners, of aligner change?
Yes, I'm usually, can you hear me?
Yeah, yeah.
Yeah, I was closing this because I wanted you to see the, let me check here. I don't know, have Supercharge. I'm changing aligners every 7 days, using or not the Accelelant. I don't mind. Using or not, I'm changing every 7 days. But a few cases in which I see that the patient is collaborating very well, I am changing every 5 days, and it works really, really well. You should understand that we are changing every 5 days, and we are moving 0.25 millimeters. So it's 10 times less than with braces. In 1 week, for example, with braces, we are moving an average 2.5 millimeters. In 1 week, 2.5 millimeters. So this is 10 times more than what we are moving with aligners. So don't be afraid about changing aligners every 7 days, also every 5 days, especially if you're using Accelelant. It's very good for tissues.
Okay, I think we have no more questions. There are some questions about the pricing, but I think as there are questions from several countries, we will answer separately because this is not, let's say the price structure to the patient is very different in Spain than in France, than in Italy or in the US. I want really to send you my warm thank you because this was a really amazing presentation. I want to thank also all the doctor who took the time to join this webinar, and we're going to try to organize some more because it looks like there's big interest. So once again, thanks a lot, Ivan. Thanks also to the guy who support the technical side. If you want to just add a word before we close the webinar.
Yes, I want to thank you for considering me as your key opinion leader or a global key opinion leader, and I'm very proud of it. I know that it's an excellent product, so I want to thank you all, Frank, Jean-Luc, everybody there, and also the doctors who are trying to improve every single day. So they are spending time with me. 1 hour a day is very important for us to grow. So congratulations, doctor. The future is on our hands, and nobody will stop us.
Okay, thanks a lot. Bye bye.
Bye bye.